Hello, and welcome to the Cardiovascular and Pulmonary Examination course. I'm Morgan Johanson. I'm a physical therapist and a board-certified cardiovascular and pulmonary specialist. Here are my disclaimers. I have nothing to disclose for this course. A little bit about myself. I'm the president of Good Heart Education, which is a continuing education company that provides live and online cardiovascular and pulmonary physical therapy training and mentoring services for PTs who are studying for the CCS exam. I'm an adjunct faculty member at the University of Toledo in Ohio. I practice at the Grand Traverse Pavilion Skilled Nursing Facility in Traverse City, Michigan. And I'm also the Professional Development Chair for the Cardiovascular and Pulmonary section of the APTA. Wanted to let you know that I'm going to teach this course using pictures, which were obtained via a Google Internet search engine, and the references to those pictures are on the corresponding slides. I'm not claiming ownership or rights to this material. It's strictly being used for education purposes, and so it will not be reprinted or copied, so you will not see the pictures in your handout. Whenever we examine a patient, we always start with the patient interview. So when we're examining cardiovascular and pulmonary patients, that is also true. We want to ask about certain aspects of their history, things like smoking history, alcohol, drug use history, their lifestyle, who is around them that can provide support. In particular with the COVID-19 patients, some of these patients might have had cardiovascular involvement during the acute phase. So it's important to ask them if they had any cardiac complications during their hospitalization. We want to know what their home environment is like, what their prior level of function is. If they are currently working, we need to know what their job is and what they will be expected to do in order to return to work. We need to know if they have a home exercise program, and if so, what are they doing? What access to exercise equipment do they have? And what their nutritional intake is. So we're always going to review patients' cognitive status, musculoskeletal system, neurological system, and integumentary system as needed. Today's lecture is specifically focusing on the cardiovascular and pulmonary system exam. Now, when it comes to COVID-19 patients who were admitted to the ICU, especially if they had a prolonged ICU admission, these patients could have experienced delirium and other cognitive changing statuses when they were in the hospital. And so they may still have altered cognitive functioning. So it's important to assess their cognitive status so that you can change your teaching techniques as needed, and you might also need to refer to other healthcare providers. The cardiovascular and pulmonary chest exam has 4 components, and we're going to talk about these each individually. First, we're going to talk about inspection, then palpation of the chest wall, auscultation of the lungs and the heart, and mediate percussion. So observation. We want to take into account what the patient's general appearance is, what facial expression they have. That can tell us a lot about how they're feeling and how hard they're working. We're going to look at the structures in their neck, how their chest wall is moving both at rest and when they're breathing deeply. We want to pay attention to their voice and the cough. And we're going to pay attention to their extremities. Now, let's dive into each of these a little bit more. With general appearance, the level of consciousness is important. Obviously, if somebody is too sleepy to participate, they may not be a physical therapy candidate that day. So we need to make sure that we have a patient that's going to be able to participate. Body type is also important, especially in the cardiovascular and pulmonary patient, because it can give you an idea of their overall physical fitness. Also, obesity is considered a restrictive lung disease, and so that is going to affect their breathing. And if they're very skinny, oftentimes the work of breathing is such that they are burning so many calories to breathe that they aren't able to have adequate nutritional status. So paying attention to their body type is important in this patient population. We want to look at their posture and their positioning. Posture, things like kyphosis and scoliosis, things that they can't change, could potentially affect their ability to expand their chest wall. How they're positioned can be altered by in our physical therapy interventions, and we may, when we evaluate them, we may find that their most comfortable position is actually not the best position for them to be exercising in or to be working on breathing. Skin tone can tell us a lot about how hard the patient is working. If the patient is sweating and red, if the patient is pale, that could mean that they don't have good circulation. We also want to pay attention to cyanosis. Signs of cyanosis could be on the lips, in the conjunctiva of the eyes. It could be on the fingertips. And then if we're in the acute care setting or the skilled nursing facility, we want to look at what equipment is attached to the patient. All right, let's look at this gentleman as an example and think about how hard he's working to breathe. Think about whether or not you think he's tired. So just looking at him, I can tell that his elbows are resting on the armrests of the chair and his hands are firmly planted in his lap. That's called tripoding, and patients will assume a tripod position because the muscles in the arms are now in a closed chain position, and so the muscles can pull on the chest wall and help the patient breathe a little bit easier. We also see his clavicle sticking out very prominently. We can see hypertrophy in his sternocleidomastoids, his scalenes, his upper traps. His lips are in a pursed position and potentially are a little bit blue. His forehead and his nose are very red. He's not wearing a shirt, which could indicate that he is actually hot and sweaty. He has a pulse oximeter on him, so we are measuring his oxygen status continuously. If we look at his rib cage, we can see rib retractions, and we can also see that his diaphragm is sucking inward during inhalation, which is the opposite of what we want it to do. So this patient is working very, very hard to breathe. There are a lot of signs of distress here, and we don't even have to ask him any questions. We can just see that by looking at him. When patients are working this hard to breathe, they are absolutely exhausted. Okay, this patient may not be able to answer questions. He may have to write. He may have to have his caregiver or his family answer detailed questions for him. So that might be important to consider when you're interviewing him. Now, besides looking at the hypertrophy of the accessory muscles and the prominence of the clavicles, in the neck, we can also look for jugular venous distension. Remember that jugular venous distension is a sign of right-sided heart failure, and it can be seen when the patient is sitting in bed with the head of bed at a 45-degree angle. You ask the patient to turn their head to the right, and you then look at the jugular vein. You wanna find the uppermost or top portion of the vein that's pulsating, and then you go to the sternal notch here, okay? You wanna find the angle of Lewis, or the sternal angle, which is about 2 fingers below the sternal notch. You should feel a ridge right there. When you palpate this ridge, it's kind of sore. That's because it's a joint. right? So if you measure the distance between the sternal angle and the uppermost point of where you see the pulsating jugular vein, that distance shouldn't be larger than 4 centimeters. If it's larger than 4 centimeters, then you have potentially right-sided heart failure. Now, this is not the only thing that a physician will use to diagnose right-sided heart failure, but it is one of the clinical signs. When we're looking at the patient's chest wall, we want to look for fixed deficits like kyphosis or scoliosis. In these patients, because of the bony deformity, their lung expansion is restricted from expanding into the area where the bony deformities are. In addition, because the bones are collapsing down onto the entire thorax in kyphosis, and in scoliosis, they're collapsing. Even the convex side is also pushing against lung material, as well as the concave side squeezing on the lungs from upper and lower parts of the bony tissue. So we have a lot of compression of the lungs, and the chest wall itself may not be able to expand. Similarly, scars or actual incisions can make it so patients can't move their chest wall freely. So it's important to pay attention to the location of incisions and scar tissue. There's some congenital birth defects that you might want to examine. The picture on the right shows pectus excavatum, and the picture on the left shows pectus carinatum. Usually, pectus carinatum does not need surgery unless it's for cosmetic purposes. But pectus excavatum, as you can see, it could potentially compress the heart and the lungs. And so a lot of patients in their adolescent years will actually require surgery for this deformity. We also have what's called the barrel-shaped chest. This happens in individuals who have obstructive lung disease like COPD. Normally, our anterior posterior diameter is half the width of our lateral diameter. But in patients who have hyperinflation of the lungs, where the air is trapped, making the rib cage fuller and more expanded, these patients will have an equal anterior posterior diameter to their lateral diameter, and so they will have what's called a barrel-shaped chest. All right, so normally the inspiration-expiration ratio, or the ratio of the inhalation phase to the exhalation phase, is 1 to 2. But in patients with obstructive lung disease, where they're having difficulty exhaling all their air, you may see an IE ratio of 1 to 3 or even 1 to 4. Now, in patients with restrictive lung diseases, in the acute care setting, and patients with respiratory distress, sometimes we can even see hyperventilation or an inspiration-expiration ratio of 1 to 1. Obviously, you can't sustain that respiratory pattern, and your systems are going to break down. A lot of physical therapists will actually palpate the IE ratio to make sure that they have it correctly. I find that it's easier to do it that way than actually trying to observe the patient. If you want to palpate it, the best place is on the abdomen below the xiphoid process. Remember that as soon as you put your hand on somebody's abdomen, they're going to probably stop or change the way they're breathing. So you have to leave your hand there for a while and just listen with your hand to how the inhalation and exhalation phase are going. And then you're going to, once you feel that it's evened out and regular, you're going to start counting how many seconds did it take for them to inhale and how many seconds did that take for them to exhale, and you should have a 1-to-2 ratio. Now, again, I find assessing chest wall motion to be easiest when you palpate, but you can see when you're looking at a patient if their chest wall is moving symmetrically. In some patients, you can actually see the recruitment of the accessory respiratory muscles. In other patients, you can't see it, but you can feel it. And that's why, especially when you're learning, the skill of palpation may be more effective for you. During the inhalation phase, you should see the diaphragm muscles and the bilateral intercostal muscles moving. And during relaxed exhalation, you shouldn't see any muscles. It's basically the relaxation of the diaphragm and the intercostals. But when we forcefully exhale, then you should be seeing the abdominal muscles contract. During relaxed breathing, we shouldn't be seeing the accessory muscles recruited. We also want to pay attention to abnormal breathing patterns, things like tachypnea, apnea, paradoxical breathing pattern, etc. Okay, now, in patients specifically with COVID-19, it's not currently recommended that you actively assess cough in these patients. This goes for patients that actually have been diagnosed with COVID-19 or patients who have possibly contracted the virus. And the reason for this is because when the patient coughs, they're going to aerosolize the virus, and that could increase your chances of exposure to the virus. And so you may choose not to actually assess the cough in these patients. But in your patients who don't have COVID-19, patients with pneumonia from bacteria, or patients with COPD, we want to assess the 4 phases of a cough because you have to have all 4 phases intact in order for your cough to be functional or in order for you to expel mucus and clear your airway effectively. The 4 phases of a cough are deep inspiration. We have to take a deep breath in. And then what a physical therapist can't see is that the epiglottis closes. Okay, if we palpate the patient's abdomen, again, below the xiphoid process, we should feel the compression phase. When they cough, their stomach muscles should be recruited, and you should be able to palpate their contraction. And then if they're able to produce mucus, that may come up and be swallowed. It may come up and be spit out. If they have any of these phases that are not intact, then they will not be able to independently clear the secretions in their airway. We also want to pay attention to those secretions. I'm not advocating that you actively examine people's secretions, but we do want to pay attention to them when we see them. How much is the patient coughing up when they cough? What's the consistency of the mucus? What's the color? Do you happen to notice an odor? How often are the patients coughing during the day? Is it just in the morning, or do they cough all the time, all day long? Do they cough at night when they're lying down and trying to sleep? And even if you don't see the secretions, you can certainly ask the patient those questions. We also want to pay attention to their quality of their voice. Are they so short of breath that they can't finish their sentences when they're trying to cough? Is their voice breathy and quiet? Are they hoarse, or are they not able to talk at all because their voice has been damaged? Remember that mechanical ventilation can damage the epiglottis and the vocal cords. And so a lot of your COVID-19 patients who were intubated could potentially have damage to their vocal cords or their epiglottis. So they may not have a functional cough going forward. All right, appearance of the extremities. When we're looking at the extremities, we want to pay attention to peripheral edema, and you can measure peripheral edema using the pitting edema scale. So remember, in this scale, a 1+ means that the skin pits, but it's only a 2 millimeter depression and it immediately rebounds. In a 2+, again, you see the skin pitting and it's about a 4 millimeter depression, and now it takes up to 15 seconds for the skin to rebound. In a 3+, you see the skin pit. Now we have a 6 millimeter depression, and it can take up to 30 seconds for the skin to rebound. And then in 4+, you have an 8 millimeter depression, and the skin is going to take longer than 30 seconds to rebound. Now, after you've assessed the edema with the pitting scale, oftentimes people will do circumferential measurements around bony landmarks to document progression and to show that their treatments are effective. Now, in the picture on the upper right, we have what is called digital clubbing. In this picture, the patient has circulation to their fingertips, but what's missing is oxygen content in the blood. When you have chronic hypoxemia, your fingernail bed will actually deform, and we call that clubbing. In cyanosis, the picture below on the right, we actually see blue tinted skin. This is a circulation problem. Oftentimes patients on some of our medications in the ICU, like Levofed, some of these patients can have blue fingers and toes because that medication draws the circulation to the heart and away from the extremities. Patients with peripheral arterial disease and diabetes can also have cyanosis in their extremities. Okay, hemosiderosis is the picture on the left. That's that brown staining, and it happens a lot in patients with venous stasis. When the vasculature leaks and fluid leaks into the interstitial spaces of the legs, it also takes proteins and iron with it, and iron is brown. Now, the lymph system of the body cannot reabsorb those larger particles, and so iron and protein would stay in the interstitial spaces, leaving that brown coloring in the skin. Rubor is that red color in the picture on the right. The patient's left leg is what we call rubor, and that can be a sign of arterial insufficiency. Okay, now when we're palpating our patients, we're going to do tracheal position, chest wall motion, diaphragm motion. We're going to palpate Fremitus and pulses. And when we're palpating the chest wall, it's important to pay attention to any areas that might be painful. So tracheal deviation can occur when there are disproportionate interthoracic pressures or lung volumes. How you assess tracheal deviation is you're going to insert just above the sternal notch, right where the clavicle joins the manubrium. You're going to stick your fingers in into the neck until you feel the trachea. And you should see that the trachea lies directly in line with the sternal notch, right in the center there. Sometimes when patients have lobectomies, pneumonectomies, the trachea would then shift towards the affected side. And sometimes when patients have pneumothorax, pleural effusions, or tumors, if they're large enough, the trachea then would shift towards the unaffected side. I remember this by thinking about the lung wall and the chest wall. If there was something inside the interpleural space, okay, like a tumor or fluid or air, it would move the lung. It would not move the chest wall, because the chest wall has more resistance, being that it's made out of bones and rubbery muscle tissue, whereas the lungs are soft, spongy tissue, and so the water or the fluid or the blood or the tumor that's in that interpleural space is going to push the lung away from where it's accumulating. So that's pushing the structures toward the unaffected side. Now, if you had a lobectomy where you took out a portion of that lung, now we have an empty space here, and that trachea via gravity is going to fall into that empty space, and so it's going to shift towards the affected side. All right, palpation of the chest wall, in my opinion, is one of our most important skills. When we're palpating the chest wall, we want to do it segmentally. We want to assess the movement in the upper, middle, and lower lung fields. We want to assess the movement at relaxed breathing and when they're taking deep breaths. We're looking for symmetry. We're looking for what muscles are recruited and what is the timing of their recruitment. How much movement are you feeling? And you want to allow your hands to move with the patient's chest wall. To assess the upper lobes, you put your thumbs on the spinous process of C7, and then you rest your fingertips over the shoulders, okay? In this position, you can easily palpate if the accessory respiratory muscles have been recruited, even in relaxed breathing and in deep breathing, okay? To assess the middle fields, you're going to put your thumbs together on the spinous process, and you want the inferior angle of the scapula to be in the V of your hand, or the web space of your hand, okay? So remembering that in this position, now we're going to be able to start feeling expansion of the chest wall laterally, so those intercostal muscles coming into play. And then you're going to come down to the lowest part of the lung fields, thumbs together on the spinous process of T10, and you're going to assess the movement at the base of the lungs, okay, both in relaxed and deep breaths, okay? When we're looking at the diaphragm, if we want to measure the diaphragm, we can do that with a tape measure, okay? And we can measure circumferentially how much the chest wall is expanding. There are a lot of different ways to do this. I actually like to measure in both places. And remember that you have to assess the difference between the expansion or the circumference of the chest wall at full exhalation and the expansion of the chest wall at full inhalation. So you have to allow that tape measure to move as you're measuring the patient. The diaphragm can be palpated below the xiphoid process, okay? And so that's where you're going to put your tape measure, and you're going to go with the tape measure circumferentially around the patient. And then the other place is axillary line, okay? And you put the tape measure on the sternum, go around the thorax at the axillary line, and then you're going to measure full inhalation, full exhalation, the difference between those two measurements. Now, normal excursion of the chest wall is controversial. The problem is that there are numerous disagreements in the literature. And so I've given you a couple of the examples that are out there. You can use chest wall excursion to write objective goals and to show that your breathing retraining has been successful. All right, Fremitus. Fremitus is what is the name for a normal vibration that you feel on the chest wall. Now, when the patient is breathing, if they had secretions in the airway, you could potentially palpate increased vibration or pronounced vibration over the areas where the secretions are. In a normal patient, the vibration should be uniform throughout the chest wall. They recommend that you palpate the chest wall using the ulnar surfaces of your hands because your bones really pick up the sense of vibration easily versus using the palm of your hands, okay? And you can have the patient repeat the word 99 and measure the vibrations across the chest wall. Now, in areas where you might have fluid in the airway, for example, in patients with heart disease, you might have decreased vibration in the bases of the lungs, usually where the fluid accumulates. We're also going to assess the patient's pulses. So this is looking at whether or not they potentially have arterial occlusions or diminished arterial flow. Skin temperature can really indicate if the tissue is not well perfused. Tissue that doesn't have good circulation will be cold in comparison to tissue that has normal circulation, which will be warm. You always want to note the quality of the pulse, and you want to compare left to right. So if you're looking at the left carotid artery, you would first assess the left side, then let go and assess the right side, okay, and compare what you palpate on both sides. Patients who have diabetes and peripheral arterial disease can have diminished pulses. Auscultation. So when we're auscultating patients, we optimally want to do this in a seated position. Now, in the post-acute setting, this shouldn't be a problem unless the patient is bedbound or wheelchair bound. In certain cases, they may not be sitting upright in the wheelchair. But if you have the option, you want to auscultate in a seated position. You also need to listen to the sounds over bare skin. When you're listening to breath sounds, you want to compare anterior to posterior, superior to inferior, and you want to compare right to left sides. You're listening for any asymmetries or abnormal sounds that you might hear. The recommendation is that you listen for at least one full breath cycle over each segment. You're going to have the patient breathe in and out through their mouth. And first, you're going to listen to quiet respiration. But if the breath sound is diminished or absent, then you want to cue the patient to take a deep breath. All right, there's two types of breath sounds. Normal are bronchial, bronchovesicular, and vesicular. Now, bronchial breath sounds are air that is traveling in the trachea. Okay, and so that's going to be the loudest. And that can be heard placing your stethoscope. Obviously, you don't want to put your stethoscope on a bone. So you want to be just to the left or to the right of the sternum, right below the clavicle. People also auscultate bronchial sounds by putting their stethoscopes right on the neck on either side of the trachea. Now, bronchovesicular breath sounds, finding that sternal angle again, right? The sternal angle is the second intercostal space, and that's the point on the body where the trachea bifurcates into the main stem bronchi. And bronchovesicular sounds are air heard in the main stem bronchi. So you would put your stethoscope in the intercostal space, in the second intercostal space on the left and the right side of the sternum to hear bronchovesicular sounds. Now, vesicular sounds is air in the periphery of the lungs or air in the alveoli. So that's going to be heard laterally in the front and throughout the posterior auscultation of the patient's back. Now, in some patients who are very skinny, you could potentially still hear bronchial breath sounds in between the scapula, but when patients have larger trunks or more adipose tissue, you should be hearing vesicular breath sounds. Now, adventitious breath sounds means abnormal breath sounds, and there's two different types. There's either continuous or there's discontinuous. Now, a lot of people have heard of these sounds being referred to as wheezing, rhonchi, and crackles, but the American Thoracic Society changed the nomenclature for the breath sounds, and so they're now called high-pitched continuous breath sounds, or what we used to call wheezing. Wheezing is an indication that there is obstruction to airflow. It's very commonly found in patients with COPD and obstructive lung disease. Oftentimes you hear it in the exhalation phase as air is trying to escape from the body. The airways are closing down, and so you're hearing the wheezing is that sound of that air trying to escape from the bronchial tube. Low-pitched continuous breath sounds, also called rhonchi, that refers to mucus or secretions in the airway. It's very loud, like a roaring sound. Remember that air or sound travels louder through a water than an air medium, and so breath sounds are going to be louder if there's fluid or water in the airway, and there's a lot of water content in mucus. Stridor is a very, very harsh sound, and it's usually indicating almost an emergent situation with the patient. Stridor can often be heard in patients who have full or almost full obstruction of the airway. So like a child who has swallowed a toy, or a patient who is not choking yet, but is on their way to choking on food. It can also occur in patients with asthma when they're having an asthma attack. And so stridor is something that you would want to have the patient immediately seek medical attention. Now, discontinuous breath sounds or crackles, that usually refers to either a collapsed alveoli or fluid in the air spaces. And it's a popping sound, but it's not going to be continuous. It'll be like pop, 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 versus pop, 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 pop. Okay, so that's why it's called discontinuous breath sounds, because it's not going to be predictable or even or heard all the time. Pleural rub, I think it sounds like squeaky floorboards. Pleural rub refers to fibrous tissue in the lungs, and so it's often heard during inhalation and exhalation. All right, voice transmission tests. One of the ways that we can find out if the patient has some consolidations in their lungs is by using voice transmission tests. If the patient has secretions in the lungs, the sounds are going to be louder, okay? And so using your stethoscope, you place the stethoscope on the patient and you ask them to say E, and through the ears of your stethoscope, if you were over an area of consolidation, you would hear A in the stethoscope instead of E. That's called egophony. Now, you could also do the test where you ask the patient to say 99, and through your stethoscope, you're going to hear it very loud, okay? That's called bronchophony. And then whispering pectriloquy is when you ask the patient to whisper, and through the stethoscope, you actually hear the words very clearly as if they were talking in regular voice. All of these tests can indicate that there could be areas of mucus in those parts of the airway. If you have weaker or softer sounds when you're doing voice transmission tests, you may have a patient who has hyperinflation, like in COPD in those patients. All right, auscultation of the heart. Now we're going to be using the bell of our stethoscope. Remember, the stethoscope has two parts to it. The big round piece is called the diaphragm, and the smaller round part is called the bell. Typically, you use the bell to auscultate heart sounds. There are 5 areas where you can hear the heart sounds the best. I use this mnemonic to help me remember. So if you start on the right side of the patient's chest wall in the second intercostal space, just on the right side of the border of the sternum, you are in the second intercostal space, and that's where it's best to listen to the aortic valve. If you go to the left side in the second intercostal space, now you're listening to the pulmonic valve. One notch down in the third intercostal space, that's called Erb's point, and that's often where you can hear S1 and S2 heart sounds the best. Tricuspid valve is heard best in the left fourth intercostal space, and in the left fifth intercostal space, that is the mitral valve. Now, when you're listening to heart sounds, you want to listen to both the rate and the rhythm. And normally, patients have 2 sounds, an S1 sound and an S2 sound. Lub-dub, lub-dub, lub-dub. If you hear lub-dub-dub or la-lub-dub, la-lub-dub, those are considered extra heart sounds or abnormal heart sounds. If the heart sound occurs after if the extra sound occurs after the S2, that's called an S3 heart sound or lub-dub-dub. If the sound occurs before the S1, like la-lub-dub, la-lub-dub, that would be called an S4 heart sound. Now, when you're listening to S1 and S2, especially in the areas of the aortic and pulmonic valves, you might hear what's called a split. And splits are considered normal if they're heard during the inhalation phase. They usually are not heard during the exhalation phase. Now, there are several different types of splits. A wide split is when you hear a split in expiration and inspiration, but the delay between the S2 sound during inspiration is further during the inhalation phase versus the exhalation phase. A fixed split is when the delay in those 2 sounds is the same, whether you're listening to the inhalation or the exhalation. And a paradoxical split is when you actually only hear one S2 sound during inhalation, but you hear 2 during exhalation, and called paradoxical because it's the reverse of what we're normally supposed to hear. Now, why might you hear 2 sounds? Well, what happens when the S2 sound occurs, you're hearing the aortic and the pulmonic valve closing. And because the pulmonic, during inhalation, there's lower pressure in the pulmonary artery, the pulmonic valve will close slightly after the aortic valve closes. Okay, so it's normal to hear a split during the S2 sound. Okay, but again, in patients who might have pulmonary arterial hypertension or patients who have pulmonary valve stenosis, you might hear wide splitting. In patients that have ASDs and right-sided heart failure or pulmonary hypertension, you might hear fixed splitting. And in patients who have aortic valve stenosis, then you might hear a paradoxical splitting. Pericardial rub is the sound that comes from friction in the parietal layers of the pericardium. And it sounds like creaking, again, like squeaky floorboards. How you differentiate that it's coming from the heart versus the lungs is you ask the patient to hold their breath. And if the creaking continues, then it's a pericardial rub. And if the creaking stops, then it's an inspiratory or pleural rub. The things that cause pericardial rub is pericarditis and cardiac tamponade. All right, there are two types of murmurs, and systolic murmurs are actually normal. We hear those in children and in women who are pregnant. Diastolic murmurs are actually pathological, and we shouldn't be hearing murmurs during the diastolic phase. So the things that might cause murmurs, I use the acronym SPASM to help me remember. So it could be stenosis of the valve, it could be a partial obstruction to blood flow, it could be an aneurysm, or it could be mitral valve regurgitation. All right, the last part of our cardiovascular and pulmonary exam is mediate percussion. Mediate percussion is when you place your finger on an intercostal space and you tap on that finger with your other hand's third finger. And you can percuss the posterior chest wall, the lateral chest wall, or the anterior chest wall. If you're percussing the posterior wall, you would have the patient sit with their arms crossed, and you would percuss on areas emitting directly over the scapula. Okay, so like in between the spinous process and the scapula. To percuss the lateral, you would ask the patient to put their hands over their head, and then you're going to percuss in the axilla. And to do anterior percussion, you just have the patient keep their arms relaxed at their side, and then you would percuss the anterior chest wall. Now you're looking for normal, dull, or hyperresonant sounds. And just like a drum, the more inflated the chest wall is, the louder or more tympanic the sound you will hear when you percuss the chest wall. The more deflated that lung is, so with restrictive lung disease, the duller the sound is going to be. Okay, so I find that this skill takes practice, so you have to do this a lot. Same thing with auscultation. A lot of people find that skill very difficult, and so it takes a lot of practice to determine whether or not you've got it. There are a lot of resources out there for you. On YouTube, you can find videos with vocal recordings so that you can actually hear what crackles sounds like. You can hear what bronchial breath sounds and how they differ from vesicular breath sounds. So you can use those videos to aid you. The more you do the skill, the better you're going to get. So if you auscultate all of your cardiovascular and pulmonary patients, you're going to get better at it if you keep forcing yourself to do the skill. These are my references. I wanted to thank you for listening to me today. If you have further questions or further training needs, I can be reached at morgan@goodhearted.org or www.goodhearted.org.